Recording in progress.
Good evening, everyone present here. I am Faraz from Clarinet. Clarinet is very proud to be a part of this session as our digital partner. Clarinet is India's largest live digital CME and doctor learning platform. With all of you, I am presenting a short video on Clarinet. Thank you so much all doctors for watching the video. You all are requested to visit our website www.clarinet.com, where you can watch lots of live sessions conducted by expert doctors across the globe. And we have MedWiki service, which is medical Wikipedia for doctors only, that you can also read. By taking not much time, I would like to hand over this session to Arpita, to
Amrita.
Sarkari ma'am. Over to you, ma'am. Kindly proceed from here. Thank you so much.
Thank you, Faraz. Please remove my CV. It's not needed. A very good evening to honorable guest, revered faculty, respected teachers, seniors, and dear friends. We all know that ovaries continue to produce small amount of estrogens and testosterone even after menopause. And we also know that even if the hysterectomy leaves one or both the ovaries, menopausal symptoms are experienced within 5 years of operation. We have been having discussion for years whether cervix should be removed or not, whether ovaries should be removed or preserved. And now, for past couple of years, there is a drive that we should preserve the uterus itself. So today's webinar is dedicated to the conservation of uterus, and we have with us the authorities in their fields as speakers who will enlighten us with their brilliance and experience. Before moving to the first scientific session, I would like to invite the president of Gorakhpur Menopause Society, Dr. Surita Karim, for her welcome address. Madam Karim is the president of Gorakhpur Menopause Society. She is a multifaceted personality, a great gynecologist and infertility specialist. She is also a social worker and a politician too. She is the first one to establish the menopause clinic in Gorakhpur and is invited faculty to various conferences. She is the director of Star Hospital at Gorakhpur. Over to you, ma'am, for your welcome address. Sorry, I think she hasn't joined yet. We have with us our patron, Dr. Reena Shrivastava, ma'am. Ma'am, please give your welcome address. Over to Reena, ma'am. Ma'am, you're muted.
Thank you, Amrita. I'm always there to help you
Yes,
all.
ma'am, thank you so much.
Surita might be a bit late. So on behalf of Gorakhpur Menopause Society, I welcome all the dignitaries over here to this very prestigious seminar, presidential seminar series. And the topic dedicated just now, we have been told that it is conservation of uterus. To conserve the uterus, we have got many methods, and interventional radiology is one of them. So I welcome the speakers, Dr. Srinivas Desai, Dr. Rohit Agarwal. Then I would like to welcome our president, Dr. Shobana, who is very energetic, very active. And so this series is going on so gracefully and academically. My welcome to Dr. Anju Soni, who is Secretary of IMS right now. She has joined from Jaipur. She too is very active and beautiful and graceful. My welcome to Dr. Jignesh. He has been in my tenure every time ready, and we have been doing webinars so many times, all the time. He graced the occasion. Thank you, Dr. Jignesh, for joining us today. Then Dr. Seema Sharma, she's here from IMS. My welcome to you. Dr. Vipasha is there, I think so. She's not seen over here.
Yes, she's there.
Welcome, Vipasha. She's treasurer from IMS. Then Dr. Ragini Agarwal, she is national convener. Then Dr. Lakshmi Shrikande is here. Dr. There are so many people over here who have joined, and the great panelists, Dr. Vikrant, Dr. Chavi, Dr. Neeti, Dr. Aradhana,
Babita.
Dr. Babita, Dr. Geeta. There are a galaxy of very good, knowledgeable people over here. I hope this seminar is going to help all the attendees in deciding how to conserve the uterus. At so many times we need interventional radiologists, although not present everywhere, but definitely when we can make it, we should make it. And my welcome, hearty welcome to all of you to be with us and make the seminar a big success. I hope the seminar is going to be a very successful one for all the attendees and all of us also. Thank you, all of you, from the core of my heart.
Thank you so much, ma'am. Thank you for being a savior all the time. And we are really honored to have our past president, IMS, Dr. Jignesh Shah, as our chief guest. Sir is a very humble and down-to-earth person. He's a senior obs-and-gynae practitioner in Ahmedabad. He's the vice president, Indian Society of Perinatology and Reproductive Gynecology. Past president of IMS, as I already said. He's the past honorary convener of State Organization of Obs and Gynae Society of Gujarat. He has held many positions at Ahmedabad and life member of all the societies associated with gynecology and obstetrics. He is an invited faculty everywhere, and his special interest is in high-risk pregnancy, infertility, menopause, and fetal medicine. And his center is recognized by FOXY for basic and advanced USG training. So we would like to hear from you and have your blessings. Over to you, sir. Jignesh, sir.
So thank you, Dr. Amrita, for very kind introduction. And let me start with a congratulations to the Gorakhpur Menopause Society, especially Dr. Surit Karim, Dr. Amrita, and founder president, Dr. Ina Srivatsav, for organizing today's webinar as a part of IMS President webinar series. Thanks for today's invite. And congratulations to Dr. Sovna and Dr. Anju also for organizing this presidential webinar series, which is now very popular, not only amongst menopause specialists, but also amongst the gynecologists across the India. So congratulations, Dr. Sovna. Friends, at present, in India, more than 20 crore women are living in midlife age group and beyond, and many of them are suffering from distressing menopausal symptoms. At IMS, our wish is that all the gynecologists should have a menopause clinic which should be dedicated for only menopausal ladies at least once in a week for a specific time. Saving the uterus as well as ovaries is one of our chief motto. And these new modalities like HIFU, that is high intensity focus ultrasound, and uterine artery embolization, these are the new modalities and which can help the gynecologist in saving the uterus. Nowadays, HIFU is very popular amongst the cosmetologists as well as urologists, but even there are papers that its role in gynec, especially in fibroid and adenomyosis, has been proved. Similarly, uterine artery embolization has saved many uterus. So all this discussion will be carried out by two radiologists, and after that, saving the uterus, the panel discussion is by our own Dr. Lakshmi Srikande, and I'm sure with this webinar, all the menopause specialists will be gaining some knowledge in dealing with the patients related with menopause. So my sincere best wishes to today's webinar, and Thanks again for today's invite. Namaskar.
Namaste, sir. Thank you so much, sir, for your wonderful words. They were so encouraging for us. My special regards to Dr. Shobna Mohandas, ma'am, who is our guest of honor today, for giving us the opportunity to be a part of this series, giving the Gorakhpur Menopause Society a chance. So this webinar series, which we are witnessing, is the concept of our national president, Madam herself. And just not academics, Madam is also very passionate about the fitness regarding mental, physical, psychological, and social health of all women. What can be better than dancing? Her Dancercise series is running parallel to this webinar series. So we are indeed blessed to have you as our guest of honor. As we already know, you are the president of Indian Menopause Society. She is also the chairperson, Women Doctors Wing, IMA Thrissur, President Mission Pink Health, IMA Thrissur. She has been the past Vice President, Secretary General, Website Committee Chair, Quiz Committee Chair, IMS. She has worked, she is a dedicated person for the Menopause Society, and she has been the member of Foxy Food and Drug Committee. She has authored 2 textbooks in gynecology and contributed chapters in several textbooks and invited speaker for more than 200 conferences nationally and internationally. We would like to have your blessings, ma'am. Over to you.
Good evening, ladies and gentlemen. I'm happy that Gorakhpur is conducting the President's webinar series now, but now there are too many activities going on, and so I'm sorry I could not personally come to give a talk on this. I said I want to know more about HIFU and embolization, and please get a few members from your own state for that. And then she got one from Bombay. She is so resourceful. I don't know, her hands move out all over India, and Reena ji and Amrita ji, they are so active. Kahin se bhi kuch bhi le aate hai, and now we are having national experts coming from Gorakhpur webinar, and we are definitely going to learn something, because the run-of-the-mill things you hear every day. But now when actual radiologists are going to come and talk to us, it will be good. And actually, I wanted a panel on fibroids, but then she has converted it very craftily into saving the uterus. So, but I hope they will be talking more on fibroids and not less on the normal adenomyosis and things like that, because we have covered it in other webinars. But anyway, Lakshmi is in charge, so let's see. So the activities of IMS, I would like to say that we also have old age homes as one of our activities. Hot flashes forms are, we have got the ethical committee clearance, and we are having around 1,500 members, and we are going to have a pan-India study on incidents of hot flashes, and it will be soon ready. And we are going to have 8 Gurukul series with Pfizer. The first one is starting in Calicut, and that's going to run parallelly. And we have our weekly webinars and 4 zonal conferences, and a lot of activities are lined up for 18th October. And I hope all of you also have physical meetings on 18th October, which is a World Menopause Day. Because all of us are celebrating it a lot. And we have our next webinar on Zoom meeting on Governing Council meeting on the November 6th, Sunday. I hope all of you are ready with your reports. And the society with the highest number of reports will be given the first chance, and so on. So, and we will have a few discussions also regarding the finances of the IMS and the journal and things like that. So this is a time for all of us to meet up on 8th of November, 6th of November. So welcome to that. With that, thank you, Gorakhpur, for getting a galaxy of speakers and panelists and panel moderators from everywhere. And so many chairpersons. I'm sure a lot of midnight oil and a lot of clicks on the WhatsApp and calling up, it must have gone behind this. I thank you for all the sweat that you have, emulated for the fructification of this particular webinar, and wish you all the best, and we are there.
Thank you, ma'am. Thank you so much. So we quickly move on to our first scientific session, and the topic is role of HIFU in uterine pathology in midlife. And for this, I would like to call upon the chairpersons, Dr. Anju Soni, ma'am, Dr. Anju Soni ma'am is the Secretary General of IMS. She is an age-defying leader, and she has led Jaipur Menopause Society and also Jaipur Obs and Gynae Society. She has been the chairperson of HIV and AIDS Committee. She is a trainer of endoscopy, master trainer of various Foxy projects, and editor of Poise magazines. She has many awards and publications to her credit. And of course, she is the invited faculty all over. Our second chairperson is Dr. Bipasa Sen. Dr. Bipasa Sen is another dedicated Menopause Society member. She has been the treasurer. She is the treasurer of IMS from 2022 to 2024. And she is the invited faculty to various national and international conferences. And she has organized zonal and national IMS-econ at Kolkata. Our third chairperson is Madam Jeena, our own from our city. She is UP Ratna. She was conferred with this award in January 2022. A great teacher, a very meticulous, par excellence surgeon, and she has been the president of UPCOG from 2015 to 2017. She is the achiever of so many awards and has many publications and awards to her credit. So over to Anju Soni ma'am for introduction of our speaker, none other than Dr. Srinivas Desai, a great interventional radiologist of our country. Over to you, Anju ma'am.
Yeah, it's my, at the offset, I would like to congratulate you, the Gorakhpur Menopause Society, and I can see so many luminaries of Gorakhpur Menopause Society, starting from Dr. Reena to Dr. Surita, the active president, and of course you and Dr. my other co-chairperson. And there are all so many people in the panel also from Gorakhpur. It's very hearty to meet all of you on Zoom. And of course, nationally, we can see my own president, Dr. Shobna Monda, a very, very strong lady and very, very dynamic and humble person, along with Dr. Jignesh. Dr. Jignesh is again another person in Menopause Society, which we vouch for his knowledge and humbleness. And of course, a lot of national people like Dr. Lakshmi Shrikande, Dr. Ragini Agarwal, Dr. Vipasa, Dr. Jyotika Desai. I can see so many, Dr. Deepa Kapoor and Dr. Sushma from Vadodara. So many people are there. Dr. Seema, all of them are there. The most important thing which you have chosen, Dr. Shobna, and the work, Amrita, you have done is saving the uterus. In Rajasthan, the women their uteruses are removed at the age of 23, 24. And I started this, work in my tenure when I was Jaipur Menopause Secretary, Secretary for Jaipur chapter, that saving a uterus is as important as saving a girl child. Especially for Rajasthan, it's been known that Rajasthan is a state where almost every uterus is removed, and without even any pathology. But whenever the pathology is, so we can imagine what is the plight of the poor woman. Along with that, the ovaries are also removed. So we have an honor of today having very good speakers from Mumbai, Dr. Srinivas Desai, who is a master in his own field. Dr. Srinivas Desai doesn't need any introduction. I believe he doesn't know us, but we have all heard of him. Can you please share his Desai? He is a director and professor and HOD intervention radiology in Just Hospital. He's also director and head of the department diagnostic in Global Hospital Mumbai, and he's honorary consultant in many places, starting from Breach, Kandi to Mumbai also. And he's a past president of Indian Society of Neuroradiology, past editor of and chief of Indian Journal of Radiology, and of course global teaching faculty member of NICR and many other associations. Welcome, Dr. Desai, and I will be very happy to congratulate to bring in Dr. Rohit Agarwal. He's another senior consultant in intervention radiology. We'll be again touching a very important topic role of UA in uterine conservation. So these are the latest techniques, though they are not available in the smaller places, but yes, they are knowledge, and if a patient can afford, we can send them to all these places. Welcome, Dr. Desai. Dr. Desai? Dr. Srinivas Desai?
You have to unmute
Yeah,
yourself.
can you hear me, ma'am?
Yes, sir.
Yes, yes.
We
Can
can
you
hear
share
you.
your screen? Dr.
Thank
Desai?
you. Yes, please. Yeah, I can. I'll just put. Yeah. Thank you for the kind words, Dr. Soni. At the beginning, let me extend my sincere thanks to Dr. Amrita, who has been following me for last more than a month, and I'm troubling her. Thanks for all that, Amrita. And I congratulate the distinguished faculty of so many gynecologists, predominantly ladies together, doing such a great work. And I'm lucky to be with you. So in my allotted 15 minutes or so, I will be talking to you about this very revolutionary modality of HIFU, which we have been practicing for last 5 years and have done more than 3,000 patients by now. So we have good experience, hopefully, and we are really very, very excited about this technology. So when we started this, I used to show this slide that it is the future of medicine, which starts here. Because when I attended the first world conference on the MR guided focused ultrasound surgery, it is called as MRGFUS. So the name itself does tell you what exactly it is. The HIFU is done under the MR guidance. The preliminary keynote address was given by a neurosurgeon, the one of the senior most neurosurgeon in US. This was held in Washington, and he said that MRGFUS is the next big thing which has happened to medicine after scalpel. So it looked more like a commercial talk to me, but then trust me, in the last 5 years, I'm getting convinced about what it is. So what is MRGFUS? It's a non-invasive MR guided focused ultrasound technology, and where you use the HIFU under the guidance of the MR to locate and target a lesion in the uterus or rest of the bodies, rest of the organs. But today's talk is only for the fibroids and adenomyosis, and ablate them under the MR guidance. Photo. So this is the presentation of how the MRGFUS works. The patient goes inside, and then with the precise localization of a uterine fibroid or uterine adenomyosis, the high intensity focused ultrasound waves are sent to different parts of the tumor and ablate them. This is a thermal ablation, and it works on a simple principle that when you destroy a tumor tissue, for 1 second, there is an irreversible tumor death at a temperature which is varying between 65 to 95 degrees. So what we are doing is basically a thermal ablation with a simple technology. So this is we call it is a cutting edge technology without cutting, because there is no incision, there is no general anesthesia, there is no radiation, we don't touch the patient. And it's all done absolutely in a non-invasive way, with exactly the way you are seeing here. The patient is lying in a prone position on the MRI table. This is a regular MRI table machine. That's the table, and underneath the table is placed HIFU, high intensity focused ultrasound. So the patient will go inside the MR table the way as they show you, and with this HIFU, we ablate the different tumors. So how does it work? If you remember, when we all were children, we used to play this game very, very regularly, holding a magnifying glass between the sun and a paper placed on the other side of the glass, and try to focus the sun rays on the paper, and paper will start burning. It's a similar technology on which you do this. Here, sun is a transducer. This is a treated spot. It's a tumor, and the energy will get concentrated there, and then pass out with decreased energy at the point where there is a conversion of these rays is where you get the complete ablation and destruction. The important aspect of MRGFUS is the MR thermometry. This is the single most important aspect because the precision is so sub-millimeter that when you are burning at the point which you want to destroy, the temperatures are in the optimal required range of somewhere between 75 to 95. But when you move away up to a point which is hardly 3 to 7 millimeter, the temperatures fall below normal, around 50 to almost 40, which do not do any damage to that tissue at all. So that is a very sub-millimeter high precision by which you will ablate the tissue which you want to. And this is how the post-treated uterine fibroid adenomyosis will look like. Then when you cut this section and look at that, that's the region which has been treated with hypo, that's a transition zone, and that's an untreated. So it is completely clear-cut margin between the treated lesion and a normal tissue. So adjacent normal uterine myometrium does not get affected or ablated or heated at all. So it remains completely intact, and only thing which you are successfully treating and ablating is the pathology. So talking about uterine fibroid and the treatment options, there was a drug therapy which was followed by the uterine artery embolization. I used to do large number of them before the MRGFUS came, and trust me, in last 5 years, I have not done a single myomectomy or hysterectomy. With the emergence of the MRGFUS in this therapy, in this protocol, the MRGFUS has emerged as one of the earlier and preferred modality. And if it can be done and successful, then you don't I presume so. You don't go for other modalities. Failing of MRGFUS then opens up other vistas. So that is how the protocol looks like today. And just a simple comparison between hysterectomies, myomectomies, and MRGFUS. As you all will understand, this is a totally non-invasive procedure without any general anesthesia. The complication rates, the hospital stay, recovery period, all are going to be pretty low. I mean, there's no rocket science in understanding that. This is a little older slide now. We have crossed this 2,500 uterine fibroids and many more adenomyosis. We have crossed almost more than 3,000 patients, treated patients by now. We are pretty lucky in that. I'm proud to tell you that we are the center that we have treated the second largest number of MRGFUS treatments in the world. So we are very lucky in that. So what are the patient selection criteria or the inclusion of criteria? Patients who are diagnosed with uterine fibroids and who are usually the criteria for the treatment. When you do the MR and you look at the fibroid, if fibroid is black on T2, the results are excellent. If the fibroids are iso-intense to the muscle, the results are good. And they are hyper-intense, they are bright fibroids, the results are comparatively poorer. When I say poor, it means if you have a fibroid of 5 centimeter size and if it is black, it takes only 1 sitting to finish that treatment. But if it is white, the same fibroid, to achieve the same kind of a treatment level, you need 2 sittings, almost double the number. And most important, they all should be enhancing. If fibroids do not take contrast, these are the fibroids we do not accept for the treatment. But normally the number of fibroids not enhancing are hardly 1 or 2%. Do we treat the pedunculated fibroids? We do. But in that criteria is when you see the attachment, the pedicle of the pedunculated fibroid, whether it is a submucous or a subserosal, the pedicle diameter should be more than 50% of the transverse diameter of the fibroid itself. If it is less than 50% of the transverse diameter, then we do not accept them because there is a chance that after the treatment they might fall off. the submucous might fall out into the cavity, and subserosal might fall off outside. So those we do not treat. What are the exclusion criteria? Those, of course, the overall anything which is MR incompatible. And what is contraindication for MR is a contraindication for MRGFS. A pregnant woman is a related contraindication, but by and large we wouldn't like to treat. Bleeding and hematological disorder again is a relative contraindication, not an absolute contraindication. Intrauterine contraceptive device, because it can be under the MR can move, but we have accidentally done few patients with the IUCD and have gotten away without any problems whatsoever. So you do a screening in all three planes, axial, coronal, and sagittal, to find out the exact location and the depth of the fibroid. And this is how you will be looking on the console. What is important is this MR thermometry. When you are ablating, you should have that optimal proper temperature at the focal spot to achieve the right ablation. And this is how a pre-treatment T2-weighted image looks like, which is black. This is the post-contrast, which is taking the contrast and is completely enhancing. And this is the post-treatment, where following the treatment there is a complete ablation. So at the end of the treatment, we inject the contrast to see is there any enhancement whatsoever in the treated fibroid. And an absence of complete enhancement is the criteria of a very good result and very good treatment. So this is how a standard well-treated fibroid would look like. Look at the rest of the myometrium, the rest of the uterus is absolutely normal. Look at the margins, absolutely normal, nothing happens. So this patient, you could see the post-treatment. This is non-enhancing, and a follow-up that's immediately after the treatment, at the end of 6 months, at the end of 12 months. What happens at the end of the treatment? The viable uterine fibroid becomes a non-viable because it's a dead tissue, and body keeps on throwing this dead tissue outside. So over a period of 3 months, the volume reduces by 20 to 25%. At the 6 months, usually by 50%, and by end of 12 months, usually between 90 to 100% of the volume reduces. There is a complete. So if the patient comes to us with a huge uterine fibroid and has a issue of getting pregnant, and if two things are together, we can never be sure. If the fibroid is causing the cause of not having the pregnancy, we advise the patients to wait for approximately 9 months to 1 year before trying and going ahead with the pregnancy. It's not easy that you'll get a nice, solid, juicy fibroids. Most of the fibroids which landed up with us in the early part of treatment, probably almost first 500, 600, were already operated and recurred, or could not be decided not to go ahead. And therefore, they have all scars and adhesions. As you can see here, the bowel is adhered to the uterus here, and you have multiple uterine fibroids. There's black spots in the uterus. And you can, if the bowel does not move away, you have to be careful because you don't want to perforate bowel. So you have to do the technical adjustments, which by now I think we are pretty good. And we can see all the fibroids which are here have been ablated, do not show any enhancement. Bowel is intact, no perforation, perfectly well. So as against this, you can equally treat the adenomyosis. Actually, according to me, MRGFS is the modality to treat the adenomyosis because there was no other treatment before this except the medical or removing the uterus. And you can see the ladies who have adenomyosis, the amount of pain and discomfort they go. And I had my own technician. She is moved over to Switzerland. She had a bad adenomyosis, and it used to push her to almost to the limit of committing suicide. Of course, she went away before we got the MRGFS, otherwise we would have treated her. Now she got her uterus removed in those days. But she cries her name. When she came down on one of the visits, she was wondering if this was there. She would have saved her uterus at that time. So a classical adenomyosis looks multiple cysts which look white, and you can treat them and see this kind of a treatment. And as you know, the aim is to completely ablate and create this area of what we call as non-perfused volume. This is the perfused before the treatment, so it's all white and non-perfused volume. And the aim of the treatment, whether it's a fibroid or the adenomyosis, accepted treatment across the world is your non-profuse volume should be 70%, so that it's a good treatment and the therapy will be good response. We have been pretty lucky in getting the NPV, that is non-profuse volume, anywhere in the range of 88 to 96%. And we have been pretty aggressive also, and therefore, hopefully, we don't have the bad results, we have pretty good results. And how do you see what happens to them? The treatment response for fibroids, there is we calculate this, what is called as SSS, symptom severity score, which this is our paper which we had sent for publication, has dropped from 7 to 2 and in a span of usually in a month. And that's any drop by more than 2 is a good treatment, and normally we achieve the SSS score down by 80 to 90%. Similarly, the SSS score for adenomyosis in our series has dropped from 8 to 2 in first 4 months. So why MRGFS? It's an incision-less treatment. It's a uterine preserving surgery. There is a low rate of complication. There's a quick recovery. Patient returns to the normal activity within days. We allow them to go back to their normal activity the very next day, but most of the patients prefer to take rest for a few days. And obviously 1 or 2 days or 3 days. But the office going people like 1 week, that's okay. We do give the certificate of that. But one of my patients didn't want to go back for a month, and she told me to give a certificate to that effect, which I flatly refused. I said, if I do that, I will be completely going against the very ethos of this particular treatment. Most important, fertility is preserved. There is very low recurrence rate, and there are good long-term results, and it's pretty cost effective because the stays are less. So this fulfills almost all the criteria of any particular surgery. What's the thing? Why is I'll put it on this. Okay. My title is hidden for some reason, but anyhow. No problem. No problem. Give it. So I'm just showing you some data of different studies which are published. This was the MRG affairs compared with the abdominal hysterectomy for treatment of the uterine fibroid, and published in the ultrasound of gynec journal. And conclusion of this study that MRGFS treatment of the uterine fibroid leads to the clinical improvement with fewer significant clinical complications and adverse events compared to hysterectomy at the 6 months follow-up. Quality of the patient preference and life quality of fibroid treatment, outcomes and the options. And this paper, again, published in the radiology, showed that there was a patient preference for MRGFS over surgery in almost 80% of the patients. I'm not trying to sell MRGFS, I'm just giving you some clinical data which has been already published. Talking about the recurrence rates, we can obviously you do expect a lower recurrence rate with the MRGFS because we can treat almost every single corner and every single point of the tumor, whether it's adenomyosis or fibroid, without disturbing the adjacent myometrium. So the recurrence rates are pretty low. This is another study published about the MRGFS treatment for symptomatic uterine fibroids in the long-term outcomes, and they showed the long-term follow-up of the MRGFS treatment showed a sustained symptomatic relief for the treatment of uterine fibroid in acceptable long-term outcome at the end of 3 years. So this is another data which has been published. When we're talking about the cost effectiveness of the MRGFS, it's easy to understand with the less hospital stay, no general anesthesia, no requirement of rest of the paraphernalia, the MRGFS is definitely going to be cost effective, cheaper. I don't want to say that. This is an important point which I would like to say. Pregnancy outcome after the MRGFS, we have our own data. In our data, 43% of our patients have remained pregnant after the treatment. And they fall in both groups, uterine fibroid and adenomyosis. Though adenomyosis group is lower in percentage, but there are quite a few patients of adenomyosis who remain pregnant, which was a very pleasant surprise to us. One of them from Cyprus, another one from New Zealand. So pregnancy experience after MRGFS is pretty encouraging. This is global data with a high rate of delivered 41% and ongoing pregnancies published across the globe. Now, this is an important thing. What is the data of the effect of the hysterectomy on the variation of the ovarian function? There is an increased risk that I don't have to tell the gynecologist. The increased risk, this twofold risk of earlier ovarian failure, is a possible consequence of a post-menopausal hysterectomy. So preserving uterus is an important factor. And this is the one I was invited to for a seminar to talk about surgery versus MRGFS. Therefore, I showed it. And so this is a regular fibroid surgery vis-a-vis. This is the MRGFS. So and these are the slides given to me by my gynec friends. These are my gynec friends. This is how skin looks after the 3 kinds of treatments: hysterectomy, laparoscopic surgery, MRGFS, unless we burn the skin. And luckily, we have not been burning the skin. And there's a surface of the uterus after the 3 kinds of treatment: hysterectomy, laparoscopic surgery, and the MRGFS. And any such thing cannot be done by one single person. You need a very good dedicated team of the doctors, the radiologists, the sisters, the technicians, the ward boys, and of course we have anesthesia standby. Though we don't give a anesthesia general anesthesia at all, but we have anesthesiologist in our team for mild sedation if some patient is hyperactive or apprehensive. Otherwise, we don't need anesthesia at all. So this is any new technology is going to kind of treat have some kind of arrogance towards the older technology, the challenge. But that's what the normal thing in the life is. And thank you so much for giving me this opportunity to share my thoughts and have my experience shared with you. Thank you very much for this.
Thank you so much, sir. And now over to Bipasa ma'am for her remarks.
Excellent deliberation by Dr. Srinivas Desai as expected. Personally, for myself, actually, I was eager to listen to you because we were aware of laser, Botox, all these things, but this is something new to us, some new technology, and I am really enriched to listen to this talk. Thank you very much for this excellent deliberation, Dr. Desai.
Thanks. Lovely. I enjoyed the being with you.
There's a third chairperson, no, Amrita?
And thank you, ma'am. Yes, ma'am. And now over to Madam Gina to conclude this session. Madam
Thank
Gina.
you very much, Dr. Srinivas, for your excellent talk. Now, conservation of uterus now is a great thing which we can do for a lady, especially for benign tumors like fibroids or adenomyosis. Now, there are so many medical treatments available, but we know that none of them is very effective, and especially long-term effects are not so good. And the HIFU and UAE are the newer conservative management which are upcoming, and we know that this is a future for conservative treatment of fibroids. Now, HIFU is we can say HIFU is the focused ultrasound. It is minimally invasive, non-surgical, highly effective treatment for fibroids that uses high intensity and highly focused sound waves into the tissue, which is heated up to 65 to 95 degrees Fahrenheit, and it causes coagulative necrosis without harming the overlying or the adjacent structures. It is the future of conservative treatment of fibroids. Now, this gives about 50 to 60% relief from pain, from bleeding, and also reduces the size of the myoma, which is comparatively long lasting as compared to the conservative medical management. Now, I think many of us have never witnessed the THIFU, how it is done, but Dr. Srinivas has made it so clear with the help of his videos that we can understand how it can be done so precisely and what are the results. It has got very minimal side effects and it is very, we can say, patient friendly because the patient has minimal side effects and patient can go home the same day and she can resume her duties next day or within few days. So it is the very effective upcoming treatment for fibroids. So thank you once again, Dr. Srinivas,
Ma'am, can
for
we
your
have a
excellent talk.
Ma'am, can we have a discussion about the cost of
Yes,
the
yes,
therapy
we
and
should
the
have a
bladder
discussion.
complications
Yes,
and the
please do
bladder
have a discussion.
complications, if any? Can we ask him if he has
Yes, yes,
encountered any
please
bladder
do.
complications?
Yeah,
Dr.
can
Desai?
you hear me?
Yes, sir.
Yes, sir.
Yes, sir, we can hear you.
Yes, we can hear you, sir.
As any treatment modality will come with certain amount of complications, side effects are there. One of them is a skin burn, especially in the hands of the people who are not highly good, and they, as I assured you, the HIFU, the high intensity focused ultrasound waves, converge at particular point, and conversion is on the tumor. But if you are not good, conversion can happen outside uterus or on the skin, and you can cause a primary skin burn. We are not come across a single case of that, luckily. There can be secondary skin burns because if the patient has already been operated and there is a lot of scar tissue in the path of the ultrasound, the scar tissue has the tendency to absorb heat and then pass it backwards toward the skin and cause a secondary skin burn, depending on that. But that, as we know, the burns are type 1, type 2, type 3. Type 1 burns by and large is just a silver nitrate application. And we have come across some skin burns because there's a short time, I didn't go into details of publication or data which we have published on that. But all of them have been the grade 1 skin burns. And there we were expecting, because of the extensive fibrosis in the path, though we put the skin patch, though we put the scar patch, all those things, in spite of that, it can happen. The second thing, which is more dangerous, we have not come across, but it's been reported in the literature, is a bowel perforation. What happens? This small bowel is a wandering structure, and sometimes it comes and sits in front of the uterus and is in the path of the ultrasound waves. And if you are not good, if you are not noticed it, and you don't push it out by filling the urinary bladder, then, and if your rays keep on going there through that for 30 to 40 minutes, long time, then bowel can perforate, which needs another surgery. So that's another complication in the, if you don't have a very effective operator and a person interventional radiologist. The third, we are not come across because you have to constantly monitor on that. And if it comes down, you have to fill the bladder and push it out. Then it's easy, nothing great. The third and more important, another thing is, after the conversion, the rays are going back. They are of the decreased intensity, but still there is a heat there. So they can hit the rectum. So what we do, we put gel, fill up the rectum with the gel. So the rectum is completely protected, nothing happens. But more important than that, the nerves which are coming out from the lumbosacral region, some nerves can get irritated, though there is what is called as a diaphragm, electronic diaphragm, which is placed in front of the sacrum so that the rays, the heat doesn't put it. Some women have got very excitable nerves, and these nerves can become something like, produce a neuritis-like picture with the pain going around the nose. But by and large, 99% of these, if they at all have, are self-limiting and usually disappear within 4 to 5 days, and all that you have to give them is a corrosive. But few patients, I had one patient from Bahrain where I had to give a steroid and the pain lasted for 5 weeks and then it went away. So these are the different complications which you can theoretically come across.
So you're giving anesthesia for these patients because they have to be under the MRI screen for a long time. They'll get
We
scared.
don't give anesthesia to anybody. Nobody gets anesthesia.
How
No.
long they have to be under the MRI machine?
1.5 hours to 2 hours.
So
And
they
they
will
are-
be there.
They're in a prone position, and trust me, if you come down and see, you'll be surprised how patient is very comfortable. We also used to think, how will they lie for 1.5 hours, 2 hours? No problem whatsoever, zero.
So can it be done only as a primary procedure, or can you do it when there is a failed myomectomy or something like that? Because then there will be bowel adhesions.
Ma'am, as I told you, first 500 patients were all post-myomectomy, failed myomectomy.
So the bowel
We never got a virgin, nice, good uterine fibroids to us. So it's one of the indications, failed myomectomy. So you do the evangelist. It can easily.
The thing is that the bowel will be in front of the uterus, in the post-myomectomy cases.
Or you don't do it immediately. You don't wait. You don't do it. You don't shift the patient from OT to. No, we don't do that.
Desai, preference whether you can get more better result in cervical fibroid or fundal fibroid. Any difference?
See, as I told you, if you look at the location doesn't matter. The size, whether it is pedunculated or not pedunculated matters. If it is a pedunculated, we look at the pedicle. If the transverse diameter of the pedicle is more than 50% of the transverse diameter of the fibroid itself, we can easily treat and it goes away. But if the transverse diameter of pedicle is less than 50% of the transverse diameter of the fibroid, we don't treat, because even after the successful treatment, it might fall within the cavity, and then you have to undergo surgery. The very thing you are trying to avoid. So it doesn't make sense. Then we allow you directly to go to surgery. Simple.
And recurrence rate, is there any difference about myomectomy and this IFU?
Sorry, ma'am, I couldn't.
Recurrence.
Yeah, recurrence rate. What is the difference between what, ma'am?
Surgery and this.
HIFU.
Yeah, I showed you the recurrence
He has
rate.
already shown.
Recurrence rate is much lower here.
But what you were showing that 12-month photo, na? The fibroid doesn't seem to have gone totally off,
No.
Photo.
That's something. So when you see at the end of the treatment, it will look of the same size. Only thing is, live fibroid has become a dead fibroid. But when you keep on, therefore we do the follow-up, standard follow-up, 3 months, 6 months, and 1 year. That's our standard follow-up. And by the end of 1 year, they all disappear.
The follow-up will be done by MRI or simple USG?
Only with MR, not with ultrasound. And that too with a plain and contrast.
What is the time interval where we can tell the patient to?
1 year, 1 year.
So what is
1
the
year.
interval of time we tell the patient not to become pregnant?
1 year is the same.
1 year.
1 year, because 1 year is the time when it is expected to go complete. If it is something which is causing the obstruction and not allowing the pregnancy to happen. But many of our patients don't listen to this advice, and they do go ahead and they try early. So there are lots of patients who have remained pregnant around 6 months, some have remained pregnant at the 9 months. But we advise 1 year.
Dr. Desai, do you think it shrinks by 100%? By 100% in all the cases in a span of 1 year? Because it is said that it reduces the size by 60 to 70%. What we have read. What is your result? Does it disappear completely in 1 year?
No, that's something. Our 1 year complete resolution is 95%. Rest of the 5%, they still are, there's some residual tumor still there. We have published this paper in I'll give you the copy of that.
Sir, what is the cost, sir? Cost?
Cost is by and large. Yeah, I'm coming to that. Cost is by and large for the one sitting is around 1 lakh rupee. 1,10,000. That's what. See, we started with 90,000, but hospital realized that we are the monopoly and the results are really good, and we need large number of patients, so they have increased the price a little. But it's around 1,10,000 for one sitting. But if 2 sitting, it's not double. I think they work up something like 1.6 lakh, something in that. 3 sittings will be 2 lakh.
How many average sittings are required? How many average sittings, sir?
One sit
No,
usually.
how many sittings? One sitting, two sitting?
One.
No,
One
no,
is enough.
I'll answer that question. A fibroid size of 5 to 6 centimeter can be, and if it's black, can be taken care of in one sitting. The fibroid size is the same. If it is white, you need 2 sittings. And if the fibroid size is larger, then obviously you know it will need more sittings.
Are there rare complications like
Sir,
severe hemorrhage and increase in the size of fibroid, sometimes severe anemia, and thrombocytopenia has also been reported. What is your you can say your observation about these complications?
We have not come across a single case of that, of any hemorrhage or any thrombocytopenia. No, not a single.
Okay.
And actually, we accept the patients with hemoglobin level of 6 also for the treatment. So there's not a contraindication for us.
Okay.
Thank you, sir. We are honored to have you at our platform, Indian Menopause Society. And I hope we'll be able to take more, knowledge from you in future. And maybe this modality becomes available all over the country in smaller cities also. And the cost of machine decreases.
Thank you, madam. And actually, it was my honor to be there with you. I'm honored and privileged. Thank you so much.
Thank you, sir. Thank you. It was our honor
Thank you very much.
that you were with us today.
Thank you so
And
much.
thank you, respected Desai, sir. Thank you, chairpersons, for the session, Dr. Anju Soni ma'am, Dr. Bipasa ma'am, and Madam Jeena. Thank you all. Now we are quickly moving on to the second session. The topic is on uterine artery embolization. And at the outset, I would like to call upon the chairpersons for this session. Dr. Seema Sharma ma'am. Dr. Seema Sharma is ex-professor and head JNU Medical College, Jaipur. She is the Vice President, IMS, a teacher, researcher, a great ultrasonologist, a member of many international societies. Welcome, Seema ma'am.
Thank you.
And our second chairperson is Dr. Ragini Agarwal. It's my honor to introduce a very, very dynamic, bold, and fearless lady, Dr. Ragini. She is the president, Haryana OBGYN Society. She's the president in SARG and national convener, IMSVP, Foxy 2020. And she is the one who brought too many new things to Haryana and Gurgaon. Welcome, ma'am. Words, I'm always short of words when I introduce Reena Srivastava, ma'am. Next slide, please. She's ex-professor and HOD BRD Medical College, Gorakhpur, very meticulous and methodical. And she's the past president of UP chapter of OBS and Gynae Society, organized many conferences and many publications and awards to her credit. So over to the chairperson, and I would request Seema Sharma ma'am to introduce our speaker, Dr. Rohit Agarwal. Over to Seema Sharma ma'am. May we have the CV of Dr. Rohit Agarwal?
Yeah, it's my pleasure to introduce Dr. Rohit Agrawal. He is an interventional radiologist with a vast experience of 10 years in the field of diagnostic and interventional radiology. He received his training in the field of interventional radiology and endovascular sciences from Sir Gangaram Hospital, New Delhi, and SGPGI Lucknow and Bakmai Hospital. His field of expertise is endovascular and non-vascular interventions with a special interest in stroke management. So he's going to take up a very interesting and important topic which we encounter in our day-to-day practice, to have the uterine artery embolization, because many times we are stuck in this type of problem when patient is not ready for getting the surgery done, and we really want some medical sort of thing, and HIFU is not available with us. So I suppose this modality is nowadays available in many cities. So over to you, Dr. Rohit Agrawal, for further enlightening us with this topic.
Am I audible?
Yes, sir.
Yes.
Good.
Screen visible?
Yeah, screen is seen. Make it full screen. Yes.
Good evening, everyone. It's an honor to present in front of such a wonderful audience, and I'm highly thankful to Dr. Amrita ma'am for giving me the opportunity to present on uterine artery embolization. So I'll be speaking on role of uterine artery embolization in conservation of uterus in midlife. I'll be discussing my talk under the following headings: briefly about technique of uterine artery embolization, then coming to uterine fibroid embolization, what are the pros, what are the cons of the technique, a brief about uterine adenomyosis, and I'll conclude. So when we talk about uterine artery embolization, first and foremost is an arterial excess. Nowadays, what we prefer is a radial artery, a 2 mm hole in the radial artery, preferably left radial artery. Earlier, we were doing it with femoral arteries, right femoral arteries. Once we have accessed the radial artery or femoral artery, we try and access the internal iliac artery. This is hardly 2 minutes job. And after that, with the help of our microcatheters, we cannulate these uterine arteries. We go beyond the second curve and bypass the cervicovaginal vessels, and so as to avoid the complication of vaginitis and cervicitis. And then we embolize the uterine arteries with the help of PVA particles or trisacryl gelatin, that is embospheres. So this is a small schematic video showing how we do it. What we do is we take our catheters right in the internal iliac arteries and in the uterine arteries. And once we have reached the uterine artery, we embolize it with the help of PVA particles. This is how the PVA particle goes, and it blocks the uterine arteries. Similarly, we embolize the ipsilateral uterine artery with the help of SEM catheters and microcatheters and deliver our particles. Once the stasis is achieved, we take out our sheets and give a compression with the help of manual compression and shift the patient for observation for next 4 to 6 hours. So what are the indications of uterine artery embolization? It can be broadly divided into two. One is uterine fibroids and the other are beyond fibroids. Beyond fibroids, we have adenomyosis. I'll be speaking about uterine fibroids today, mainly about uterine fibroids and briefly about adenomyosis in a slide or two. The other indications, which are uterine vascular malformations, morbidly adherent placentas, and postpartum hemorrhage. We can cover this in some future webinars. So when we talk about uterine artery embolization, we must be aware, we must know what was the history behind it. So uterine artery embolization is not a new technique. And the first case of uterine artery embolization dates back to year 1974, where Dr. Jean-Jacques Merland did it for the first time. Then with the collaboration with Dr. Jacques Ravina, a gynecologist, a multi-center trial was started as an alternative for myomectomy, the results of which were published in 1995, I believe, in Lancet. So this is the case report, first case report of arterial embolization in the treatment of metrorrhagia of tumoral origin. Coming to uterine artery embolization, uterine fibroid embolization per se, it is generally done in symptomatic patients which are not controlled with the help of medical management. Complaints which we look into is pain, pressure symptoms, menorrhagia, and it is also indicated in patients with fibroid-induced infertility who are not candidates for surgery. This is the indication which we normally do not take, but yes, in literature it is given. The anatomical criteria is for eligibility is that all types of fibroids are eligible. It can treat all types of fibroids and number of fibroids at the same time, since both the uterine arteries are taken care in a single sitting. Single or multiple, all locations, small or giant. But yes, there are special scenarios such as in giant fibroids, the response may not be complete and patient might require and will require in most of the cases a re-intervention. Cervical fibroid may not respond completely and generally we avoid these patients. A pedunculated fibroid, subserosal or intracavitary fibroids. These are the fibroids where we try and avoid embolization because in pedunculated subserosal fibroid, there's high risk of peritoneal migration, henceforth high risk of infection, peritoneal infection. In intracavitary fibroids, there is higher risk of expulsion. When we talk about fibroids, there are multiple pros, but it comes with a salt. Pros are, it is a global treatment wherein we can treat all and every kind of fibroid in a single setting. It is uterine sparing treatment. We can save the uterus. It is efficacious, and the recovery time is really low. The cons is the issue of fertility. The impact of fertility is still not known. We try and avoid these procedures in a nulliparous female or a female who is desiring a future pregnancy. The problem of residual and recurrent disease, it is there with all the uterine sparing procedures, so as with it. The issue of fibroid passage and intracavitary fibroids and post-operative pain. In many patients, the pain is severe, but with the advent of recent NSAIDs blocks, and epidural anesthesia and epidural pain blocks, the pain is not dealt with easily. So it is the only global treatment other than hysterectomy, wherein we can tackle all kinds of fibroids in a single simple setting. The size that I've mentioned about HIFU, that with HIFU also we can tackle all the fibroids in a single setting. But HIFU is, I think, hardly available in India. It is 1 or 2 centers are only there which are treating the fibroids with HIFU. Like in this example, we can see that there are multiple fibroids. It's a situated image. You can see that there's multiple fibroids all across the uterus. And this is a follow-up image after 6 months, where we can see that almost all the fibroids are now necrosed after the UFE. And the size of uterus is now reduced to almost 50%. And this patient was having a uterus up till the umbilicus, just below the umbilical level. And in the follow-up at 6 months, the uterus was not palpable. The uterine sparing, when we talk about uterine sparing, there was a landmark paper in year 2018, wherein they compared cardiovascular and metabolic morbidity after hysterectomy, even with ovarian conservative therapy. They took into account 2,100 women who underwent hysterectomy with ovarian conservation for benign indications. Most indications were of bleeding disorders, leiomyomas, and uterine prolapse. And it observed the females who underwent hysterectomy between the years 1980 to 2002. All of them were included. The median follow-up was of 22 years. And remember that this paper was published in 2018. What they say that there was an increased risk of metabolic syndrome in the females who underwent hysterectomy, even with ovarian conservation. There was increased risk of hyperlipidemia, cardiac arrhythmias, coronary artery disease, hypertension, and congestive heart failure. This is a table from the same paper, wherein the statistically significant risk was seen with hyperlipidemia, hypertension, obesity, cardiac arrhythmias, and coronary artery disease, and also with congestive heart failure. When we talk about efficacy of uterine fibroid embolization, it is really effective. The leioma size reduction has been rated. What happens is when we talk about size reduction, we have to follow it up. It is it is something which is seen in 6 months to 1 year. The leioma size reduction is up to 50 to 60% at the end of 1 year. Uterine size reduction is up to 50% at the end of 1 year. The reduction in the bulk symptoms is up to 92%, and the acceptable rate is 80%, which is very good. The elimination of abnormal uterine bleeding is more than 90%, and successful elimination of symptoms is around 75%. And patient satisfaction, when we compare it with any other uterine sparing surgery, it is comparable. And in the FEMA trial, which came in 2020, I think the quality of life standard was similar in both. It was 4 points was less in uterine artery embolization, which was statistically not very significant. The complication rates with uterine artery embolization are really low, with no major complication as such if we are doing it in a selected group of patients after doing a proper MRI and proper evaluation, like not including the intracavitary fibroids and everything, or subserosal fibroid, pedunculated fibroids. In comparison with myomectomy or hysterectomy, the complications are really low, with no major complications seen. The recovery time, when we compare the recovery time between myomectomy, embolization, and hysterectomy, the length of hospital stay is hardly a day in UFEs. In fact, in our hospital, what we do is we discharge these patients most of the time on a same day, and the patient can resume the normal activity by the end of first week. Now coming to cons, yes, the problem of fertility is there. And when we talk about it, the FEMA outcomes, they showed that similar results between myomectomy and uterine artery embolization, but the data was not, when we dissect through the data, what was there was that the most of these patients were of the perimenopausal age group. And the other paper, which was with Mara et al., what she suggested was that there was a lot of the rate of conception was really low, which was somewhere around 16-17%, 16-17%. The rate of conception was low. The risk of abortion, early abortion, was very high, ranging up to 50 to 60%. However, once the pregnancy reaches full term, then the rate of complication was similar in both myomectomy and embolization arm. Less invasive nature of UAE needs to be balanced against the reintervention. What we say is in long term, that is in when we talk about 5 years and 10 years interval, then almost 20 to 30% of the patients might need reintervention when we talk about uterine artery embolization, or might need a hysterectomy. But yes, hysterectomy can be avoided in up to 70% of the patient, which is a huge number. Fibroid passage is another complication. This is, I would say, one of the most dreaded complication when we talk about UAE, and it can, when these are the result of FEMA trials, the overall complication rate is somewhere around 4.57%. But if we are able to select, like we do around 100 or 150 fibroids in a year, fibroid embolization in a year. When I talk about my own complication rate or the complication rates in our institute, I would say that the rates are somewhere around 1 to 2%. We don't choose intracavitary fibroids. We generally ask our gynecological colleagues to look into it. And that's how, with the experienced hands or in a centers where the numbers are high, like more than 100 a year, these fibroid passage and other complication rates can be reduced. Now, coming to the contraindications, the contraindication for uterine artery embolization is current pregnancy. It's an absolute contraindication. We cannot do it. Known or suspected gynecological malignancy, hysterectomy should be done, or other therapies which are there. Current uterine or adnexal infection. Relative contraindication include contrast material allergy, renal failure, and coagulopathy. So, UFE versus hysterectomy or myomectomy. Is it a tug of war? Is it a tug of war? Not really. These are the different trials which has been comparing UFE versus hysterectomy versus myomectomy since 1995. The result of ME trial came in 2005, then in 2010, which compared with UFE with hysterectomy. And the result of REST in FEMA came, REST in, I believe, 2012, and FEMA in 2017, then 2020, which compared UFEs with myomectomies. So when we talk about the ME trial, what they said was that there was no significant difference in quality of life at 10 years between UFE and hysterectomy. No significant difference in symptom improvement at 10 years between UFE and hysterectomy. No significant difference in patient satisfaction. So definitely UFE is faster. Definitely UFE has faster recovery, lesser hospitalization, and much lesser complication. And there is a higher intervention rate, but yes, at the end of 10 years, 69% of UFEs avoided hysterectomies, which is a high number. And thereafter, ACOG accepted UFE as a primary treatment in symptomatic fibroids. When we talk about FEMA trials compared between the UFE and myomectomy, what it said was quality of life at 2 years, the difference was 8 points, which was statistically not different. And at 4 years, it was 5 points, representing a very small standardized, statistical difference, which is unlikely to be clinically significant. The impact of myomectomy and UAE on fertility could not be commented upon. So UFE versus surgery, it is not a tug of war, and it can, we can say it can go hand in hand. Then now coming to UAE beyond fibroids, I'll just speak about uterine adenomyosis. So when we talk about uterine adenomyosis, we must know the pathology of uterine adenomyosis is slightly different from, or completely different with from the uterine fibroids. In uterine adenomyosis, there is migration of normal endometrial tissue in the myometrium and it is a global disorder. It is a global disorder, and the patient presenting symptoms are quite similar to the fibroids. However, the age is generally perimenopausal. When we talk about uterine artery embolization in adenomyosis, we must understand that what we do is we try and embolize both the uterine arteries, and the short-term results are quite good with adenomyosis, but underlying pathology is not treated. And when we talk about the results are somewhere around 74 to 80% if it is being done in pure adenomyosis group. However, in short term, the results are very good and ranging up to 90 to 95%. Short term is 1 to 2 years. So this is, I'm just showing a case of uterine artery embolization in case of adenomyosis. So what we see is that in uterine adenomyosis, there is globular blush in comparison with a focal blush, which is seen in uterine fibroids. So this is a uterine angiogram done from right uterine artery, which shows whole abnormal blush. And this is the angiogram which is done from left uterine artery, which also shows whole globular blush. And this was the follow-up of this case. There was almost complete necrosis at 6 months, and the patient is still doing well. So in conclusion, UA is the only uterine sparing treatment wherein all types of fibroids can be treated in single setting. Uterine sparing treatment should be the first line of treatment in conditions. There is myomectomy, HIFU, uterine artery embolization. Awareness of uterine artery embolization is critical, and a close relationship with your gynecological colleagues is a must to provide a better and best care to the patient. Thank you. This is my team, comprising of Dr. Gaurav Chauhan and Dr. Amreen Isra. Thank you all.
Thank you so much, sir, for your wonderful talk. And now over to Ragini ma'am for her remarks.
Thank you, Amrita, for inviting me such a new topics which we are discussing. Although I can't say that HIFU or UAE is something new in the field, but we are discussing very rarely its use. And no doubt, Dr. Agarwal, your talk is very crisp and very clear and to the point. Today, we are all for the save uterus policy. We don't do the hysterectomy unnecessary and try to conserve. And very rightly, you have said that even after hysterectomy, ovaries are remained, but it can lead to the problems, maybe metabolic problem or premature menopause. So these type of the modalities are really very, very useful. My personal experience with the UAE is in the cases of the PPH in 2 or 3 cases, and we find it very good. As far as UAE in fibroid, we have never encountered any case for that, but after this particular interesting talk, we'll try to send our case and have our own data also, how they are going to be happen in this case. Thank you so much. Over to you, Amrita.
Thank you, ma'am, for your remarks. And now over to Madam Reena Srivastava for conclusion of this session.
Thank you, Dr. Rohit, for the salient features of this procedure. Basically, these modalities would be fit to do in the cases who don't normally require for pregnancy. Nicely, the topic has been nicely defined as it being in midlife, 40s mid. So in those cases, if the patient is not requiring any pregnancy and she's still far off menopause, for those cases, it would be very right to do it so that the patient can have the good results for the rest of her premenopausal years, number one. And number two, her ovaries is spared in the premenopausal age group. But if the patients are at the edge, say around 50, 51, those cases, they'll be definitely having better results with hysterectomy if the case is adenomyosis or very big multiple fibroids. This is my opinion. Definitely, the results of the shrinkage of the tumor in these cases is around 50-60%. There are chances of complications also, few 1 to 2%. There are chances of recurrence also, but definitely for 40s who are far from their menopause, we can offer them, and it is a very good modality. And this modality has been well tried for PPH and placenta accreta, giving very, very good results. So what I feel that definitely midlife, it can be very helpful to the patients, but it is not available everywhere. How many case series have you done in your practice, Dr. Roy?
Ma'am, I regularly do around 100-150 cases in a year. That is somewhere around 5 to 10 cases in a month.
Fine, fine. So there would be more cases pouring into in your clinic from other places also. And what about this procedure you people do? How do you tackle it in cases of PPH and placenta? Do you do it in your place?
Yes, ma'am. We do PPH somewhere around one case per 2 months. These are generally the cases which are referred from outside centers, from nearby places. PPH cases. In-house PPH is quite low in our own center. We also do with morbidly adherent placenta. In morbidly adherent placenta, if the child is alive, what we do is we preoperatively place the balloon in both the arteries.
That is the advantage of you people having in your own institution, that these can be placed pre-hand, and after taking out, after clamping, then you can shoot it out. That is giving very good result. So for fibroids, definitely very good for 40s.
But what I have
But
heard
if
about,
the person, the lady requires a pregnancy, then it is not advisable.
no, but what I have heard about is that it causes some patient, it causes a lot of discharge and pain.
Yes.
What is your take on that?
Ma'am,
1 to 2% can have it, no?
Actually, what happens?
No, I have heard in more patients. That's
yeah. So what happens is when I started my practice around 5 years back, so the anatomy is very, very important. Like what we try is we always do it with microcatheters, and preferably a smaller microcatheters, so as we can pass the cervicovaginal branches. Vaginal artery are most of the times we can see arising directly from internal iliac artery also, but we need to avoid these cervicovaginal arteries which are arising
Amrita, we have
uterine arteries, and we try to embolize only the ascending limb of the uterine artery, and also we try to stop our embolization when the abnormal blush is gone. It is not something that you have to just embolize everything out there. So when we talk about, when I'll talk about my last maybe 200-300 patients, then the vaginal discharge has not been there, maybe around 1 to 2%, but not more than that. We have learned from our mistakes, I can say that.
but I have heard lot of recurrences there after this problem.
Then probably you need to change the radiologist.
No, if you're doing around 40s, it is going to give a good result for the next, say, 8 to 10 years, what he says. Until then, there is menopause, and then the things are over.
Yeah, but what I have seen practically,
okay, Anju, the discussions will going into different level now.
Okay,
I know, I understand.
Put a marina, Dr.
Go into
Reena.
that.
Dr. Reena, put a marina. Patient will go for 5 years, then put a marina, and there's a menopause.
Yeah, that is also.
And patient is with you.
Very
Let's
good
go into the
modality
next
with
talk
us.
because the clinic will give us max to max up to 9:30.
Yeah.
Okay.
So we conclude the session over here. Very nice and bright talk, Dr. Rohit. Thank you for that. And Amrita, over to you.
Thank you, ma'am. Thank you, Dr. Rohit, for a wonderful talk. Thank you, Reena, ma'am. Thank you, Dr. Seema Sharma. Thank you, Ragini, ma'am, for chairing this session. So now we have a great panel on conservation of uterus in midlife. And for this, we have a beautiful, brilliant, and a great academician, Dr. Lakshmi Srikhande, with us. She'll be moderating this session. She's the chairperson-elect, ICOG, Indian College of Obs and Gynae, National Corresponding Editor, Journal of OBGY of India, JOGI, National Corresponding Secretary, Association of Medical Women, India, founder, patron, and president of ISOPAR Vidarbha chapter. She has so many awards to her credit and received appreciation letter from Maharashtra government for her work in the field of Save the Girl Child. She is the invited faculty and most sorted moderator for any panel. So over to you, Lakshmi ma'am, for this session.
Thank you. Thank you so much, dear Amrita, and hats off and appreciation to Dr. Shobna for having this dedicated webinar on conserving the uterus. And I'm so happy with the selection of topics that whenever any perimenopausal woman comes with fibroid or adenomyosis, the first thing is told to her is, now you have finished your childbearing, get rid of your uterus. So I'm so happy that these two radiologists have covered the uterus conserving therapies for fibroids in perimenopausal woman. And I am covering the third aspect, which is also very crucial, because whenever a perimenopausal woman comes with hyperplasia, she is told that गर्भाशय में cancer हो जाएगा, get rid of your uterus. So I am mainly focusing on this aspect during my panel discussion. These are the esteemed experts who will be answering your all the queries, and why we have to talk about saving the uterus or conserving the uterus, because everyone feels that as soon as childbearing is over, it has no role to play. This is the study published in Times of India, where they have said that 80% of Andhra village women are minus their uterus. The findings of another study reveals that 6 in every 100 women aged between 30 to 49 have had a hysterectomy in India. So the prevalence of hysterectomy is about 11 per 100 women in this age group. This is the usual roadmap in India, that because of so many reasons, they are coaxed into getting hysterectomy done at perimenopausal and menopausal age group for white discharge PV, for uterine fibroids, for endometrial hyperplasia, or many other reasons. And this was the infamous case which was published in Times of India. This bleed is in Maharashtra, where rural women who were working in sugarcane factories, just on the pretext of heavy menstrual bleeding, they were coaxed to get their hysterectomy done by their employers. But remember, hysterectomy is not without side effects, as previous two speakers have already highlighted that it does affect the ovarian function once you remove the uterus. So let us focus on how to save the uterus. So whenever we are saying abnormal uterine bleeding, first and foremost is that we should know what is normal uterine bleeding. Palm coin classification, everyone knows. So I'm straightforward, starting with the case discussion. So this is the case for you, Jyoti. She is a 44-year-old woman. This is a very common scenario in our OPDs. She has 2 vaginal deliveries in the past. Last childbirth was 10 years back. Now she has come to you for heavy menstrual bleeding. I really want you to focus on actually whether this is really heavy menstrual bleeding or it is just a subjective feeling. So how you will assess this aspect before proceeding further?
Good
Jyoti?
evening, am I being heard?
Yeah, you are heard.
Yeah. So good evening. No, the proper assessment of really how much is the blood loss is very much important, and you have rightly put these slides in front of me, that the size of the pad, the area absorbed by the pad, the number of pads changed, the time duration between the pad changing, all those things are very, very important, so that we can very well calculate the overall amount of the blood loss. So for some patient, a small bleeding, only spotting, but because she is not feeling it well and changing the pad, and she says that I am changing 6 to 7 pads per day. That may be a big amount for us, that 6 to 7 pads per day is a larger amount. So looking at that area is also important. Apart from that, the clinical assessment adjacent to the history she is giving, whether she is really that pallor, that much pallor she is having, or how long is the history. That all things are required to know well and assess well.
Yes.
before directly taking into the mind that this is a patient of HMB and we have to write down either a medical or a surgical management for it.
So point well taken, Jyoti, because you have to assess as a treating doctor, you should know that she's really having heavy menstrual bleeding and it is not a subjective feeling. So objective assessment of this complaint is very, very important. And you were just saying some points which you would like to highlight in history taking. Can you just elaborate very important highlights, because all the audience is our already renowned gynecologist, but just few highlights what they should take in history taking. Yeah.
History taking. Number of days, whether the previous, how was the previous cycle earlier and present last 6 cycles, how was they? And after that, how many pads she were taking earlier, now how many pads she are taking, which kind of pad she is taking, homemade, house-made or the marketed pad, the average size or the larger size, is it fully soaked, not soaked fully, that much, is it associated with clots or not, is it associated with the painful passage of the bleeding, whether the unclotted material is also more, whether they have this is affecting the their daily day-to-day work pattern, they are able to go to their work or they are not able to go to their work. All these things are important in this.
Yeah.
And if they can take a picture of those pads, then nowadays even I told to my patient ki jab bleeding hota hai, initial days, and sometimes they say that I am having 10 days bleeding, though it is either a premenstrual spotting or postmenstrual spotting for 4 days. So that point is also important. And if when they are having the heavy bleeding, I tell them to take a picture of the pad also.
Yeah. Jyoti, very well said that detailed menstrual history taking is very important. And yeah, dear friends, don't forget to ask the history of coagulopathy, though it's not a very common picture in a perimenopausal woman with heavy menstrual bleeding.
Also, I forgot to mention about the medication history.
Yes, medication,
are they on any aspirin or any kind of anticoagulant therapy? Because perimenopausal and patients can have such kind of problem associated with the cardiovascular.
Also, Jyoti, contraception history, because one 47-year-old lady came to me with heavy menstrual bleeding. She was prescribed very high doses of progesterone, but when I did a post speculum examination, it was a case of incomplete and inevitable abortion. Yes. So don't forget that this bleeding cannot be because of pregnancy related complications. So do ask that history as well. And now I am coming to the very important aspect of which is a neglected art. Now we gynecologists just directly put our transvaginal probe and we forget to do the general and systemic examination. So Dr. Aradhana, what is the importance? What points you would like to see in this general examination and systemic examination? Aradhana, are you there?
Well, madam, for examination, hello?
General and systemic only. Pelvic, I am coming in my next slide.
Okay, ma'am.
Will you do general examination?
Of course, ma'am. This is to exclude any chronic disease. If the patient is having like hypertension, diabetes, or thyroid disease, or any cardiovascular disease, or like you said, coagulopathic, like petechiae, bruising, etc. And
hepatosplenomegaly.
Hepatosplenomegaly, to rule out any liver or kidney disease.
Pallor, the degree of pallor. There are so many things. If you just take out 1 minute to look that woman as a whole, then you can gather many crucial aspects about her condition. So they're now coming to the pelvic examination, because see, we have to go step by step. So before putting your TVS probe, what is the role of pelvic examination?
Pelvic examination is very crucial in this case, because we want to exclude any organic pathology, and the history and examination both would give rule out endometrial or uterine organic pathology like polyp, myoma, adenomyosis, etc.
Because if you don't put your purse, if you don't do speculum examination, the large fibromatous polyp or the cervical polyp or a big erosion or the local causes of cervix and vagina can be a reason for heavy menstrual bleeding. So I emphasize to all the audience in every webinar that please put in a speculum and see what is going on before putting your transvaginal probe. And of course, you are supposed to use your fingers and do a proper per vaginal examination. So Dr. Vikrant, now you have come to this stage for this lady. So transvaginal scan, what you will aim for or what you are looking for, because your eyes can't see what your mind doesn't know. So now from your history examination, you must have come to certain differential diagnosis. So just elaborate on the points on TVS.
Good evening, madam. Good evening, respected seniors and colleagues. Hope I'm audible.
Yeah, you are audible.
Great. So in these type of cases, we should start our examination methodically. Cervix, uterus, adnexa, or from endometrium and out. And now there's a laid down guidelines we should follow are this Palm-Cohen classification. Look for polyp, adenomyosis, leiomyoma, and malignancy and hyperplasias. These are the structural abnormalities which we can get in these type of cases. Other in the Cohen part, in coagulation profile, we don't get to see anything on TVS, but for ovarian pathologies, we can see conditions like PCOD, and for endometrial pathologies, we can get
yeah, you covered in that palm, because basically structural things, the structural causes, that is the palm thing, you can see on transvaginal sonography.
Right.
Yeah. Now you are doing your own TVS scan, I believe, and you have seen that she is having day 5 of the cycle and endometrial thickness is 15 millimeter. What next? She is 44-year-old lady, came to you with heavy menstrual bleeding. On day 5, ET is 15 millimeter.
So, madam, ET is obviously very thick for the, this is early proliferative phase. In this phase,
15 millimeter is not, yeah, she is in early proliferative phase, but she is having hyperplasia. Yeah.
Yeah. So, this is a clear-cut indication for endometrial sampling or endometrial histopathological correlation, either by biopsy or by
yeah, you
other
are
methods.
absolutely right, because this is the clear-cut indication for endometrial evaluation, and there are various ways of doing endometrial sampling. Remember, it is very, very important. Just don't tell patient ki nahi endometrium bahut jada hai, malignancy hoga. Go on, because absence of proof is not equal to the proof of absence of malignancy. So pathologist can only diagnose what is in the slide and not what is in the patient. So now I am coming to Dr. Babita, because till now we were talking about blind DNCs or blind biopsy. Do you feel that there is any role of hysteroscopy in this woman, or in short, tell the audience about advantages of directed biopsy over blind DNC?
Yes, ma'am, hysteroscopy definitely has an edge over blind DNC because at times we tend to miss certain lesions in ultrasound, and suppose we are taking DNC and we do not know the exact location where the pathology lies, and we might miss the chances of detecting endometrial cancer. And if you are taking it hysteroscopy guided biopsy, then the chances of missing will be less. Though hysteroscopy is not indicated in all cases of AUB, but then those patients who continue to bleed in spite of treatment, they're not responding to treatment, or those patients where we suspect intracavitary lesions, they're like polyp or some other lesion, we should go for hysteroscopy. Or those patients with intermenstrual bleeding, or suppose we endometrium ultrasound suggests there is a thick endometrial hyperplasia, and we have a DNC which gives an inadequate specimen or a scanty specimen, then we should go for hysteroscopy to rule out polyp. And there is dyssynchrony between the patient's symptoms and the report. So all these patients, we definitely hysteroscopy has an edge, though it is slightly costlier, and not all patients might like to go for it.
Yeah.
But then we should counsel the patients
Yeah,
that yes, it
Babita,
has an
your
advantage.
point is well taken that it is not indicated in all the patients of HMB. You can do your office endometrial biopsy, and you have rightly put out the indications for hysteroscopy. That is, if the symptoms are persistent after a negative initial biopsy, because in these cases, there is an 11% risk of an existing lesion which has been overlooked. So as a treating doctor, it is your call to decide whether you want to go ahead with endometrial biopsy, or there is an indication for hysteroscopy and directly taking a biopsy under vision. Because all said and done, as Dr. Babita has said, hysteroscopy, office hysteroscopy is the gold standard for endometrial assessment. And here now we have thinner scopes with us. They are patient friendly. Anesthesia is not required. You can take targeted biopsies. It is see and treat approach and cost effective. When all the urologists can do office hysteroscopy, why can't all the gynecologists do office hysteroscopy? So it is need of the hour that each and every gynecologist should be well trained in doing office hysteroscopy. Now, Dr. Geeta, the histopathology has come as endometrial hyperplasia without a TPA. Because now WHO has made the classification very, very simple. We no more talk about cystic hyperplasia, glandular hyperplasia, or adenomatous hyperplasia. There is only two categories: endometrial hyperplasia with a TPA and endometrial hyperplasia without a TPA. So in this histopathology report, what is the risk of carcinoma endometrium? She is very scared. She is telling you that, madam, there is a hyperplasia. You remove my uterus. So how you will counsel her?
Good evening, ma'am. This is a case of hyperplasia without atopia. There is a chance of less than 5%, because if it is simple, then it is less than 1%, but it's complex 4%, around 4%. So the chances are very rare, and they're very rare for the carcinoma endometrium. So the patient should be informed and counseled regarding the chances and about management part, because we should convey a message that this case is treatable and hysterectomy might not be required for this case, and there are medicines which are quite effective.
We will come to the treatment part. Dr. Geeta, you are absolutely right that first and foremost, the treating doctor has to be confident that this is not malignancy, and that is why I have put up this slide that there are n number of studies which tells you, as you rightly said, the chances of malignancy is less than 5%. You have to inform the woman that with progesterone there is a higher regression rate, but simply with observation also there are chances of regression of this hyperplasia.
But there are some risk factors which we have to see.
Obesity, if she's on HRT, of course,
or
you
Lynch
have to find
syndrome,
out.
or the patient is of Lynch syndrome.
Yeah. Yes, you are absolutely right. You have to find out the risk factors, but be sure, be confident when you are counseling this woman. So, Dr. Rita, all said and done, we are talking of conserving the uterus. But there are some candidates with this histopathology who really need hysterectomy. So, who are those candidates whom you will advise hysterectomy even with this histopathology report?
First, madam, we will put this patient on the medical management, and we will tell the patient a regular surveillance is required, and you should be compiled with the treatment and surveillance 6-month interval. If there is a persistence of this hyperplasia even after 12 months of surveillance of endometrial biopsy, then if it progresses to a typical hyperplasia, or if there is a response after 6 months or 12 months, we keep the patient on high risk for follow-up biopsy, and if there is relapse of hyperplasia, and if there is even after treatment, medical treatment, there is persistence of symptoms and patient is not well, is not compelled with the treatment and the follow-up. These are the patients we should really think for a hysterectomy.
So you are absolutely right that this is not the first line treatment, but there are indications for hysterectomy even in this histopathological diagnosis as well. So Neeta, now as already discussed that she is for medical management. So would you like to tell the audience the role of oral progesterone versus LNG, which one you will prefer and counsel? Hello, Dr. Neeti, are you there with me? Anyone?
Am I audible, ma'am?
Yeah, you are audible. Yeah, Neeti.
Ma'am, both the oral progesterone and the LNG have the potential to decrease the blood loss by 80. The progesterone decreases by 80% as compared to levonorgestrel, which will decrease the blood loss by 65 to 98%. So levonorgestrel will have an edge over the progesterone, and also the levonorgestrel is being absorbed in the systemic circulation as low as 0.4 to 0.6 millimoles per liter. So when we compare the systemic side effects, they are quite low with levonorgestrel. So levonorgestrel will have an edge over the progesterone when we compare the side effects. The headache, irritation, acne, the water retention, these all side effects are much more with oral progesterones as compared to levonorgestrel.
Yeah, you are right that LNG IUS should be offered as the first line treatment unless and until it is contraindicated. If it is contraindicated, then of course think of oral progesterone. And once you are thinking of oral progesterone, it has to be a continuous progesterone and not cyclical progesterone, because cyclical progesterone will not help you in regression of this hyperplasia. So this is the dose. In this dose, you can start your oral progesterone. So now can you comment on the surveillance? Because if she is on medical management, yes, surveillance has to be there. So how frequently you will call her? How frequently you will do her DNC?
Ma'am, if it is a case of simple hyperplasia, we will call her 6 monthly. We will take 2 consecutive biopsies. If they come negative, then it's okay. And the dose is 20 milligram per day daily. MPA.
Yes. Now let us come to this case 2, because case 1 is already well discussed. I am sure the points are well taken in the first case, that if it is endometrial hyperplasia without atypia, LNG IUS is first choice. If it is contraindicated, oral progesterone. In that also continuous progesterone. But there are few cases who do require hysterectomy in that case also. Now let us come to this second case. She is a 42-year-old woman, but she is very keen to conceive. This is a very common scenario now in our OPD because of late marriages, because of the lifestyle changes. Many women are coming in their 40s that they are keen to become pregnant. But her BMI is 34 and she has come to you with history of HMB, but she is keen to conceive. So now, Babita, what will you do? Will you look for her antral follicular count? Because when you are doing her TVS, her endometrial thickness is 12 millimeter. Babita?
Ma'am, she is Babita Kapoor.
I have written Dr. Babita Kapoor because there were two Babita. Yeah.
Other Babita will answer.
Yeah.
I think she's not.
Do you want to see her antral follicular count? I know we will do her AMH, but she is 42-year-old. So definitely ovarian reserve is expected to be on the declining side. So antral follicular count matters a lot. So Dr. Babita Kapoor? Anyone can answer?
Ma'am, as endometrial thickness is 12 millimeter on day 2.
Yes.
So it is a case of endometrial hyperplasia. First, we have
Yes.
to rule out any pathology in the endometrium. Then only we can go for the infertility treatment.
Great, great. Now the histopathology report is endometrial hyperplasia with a TPR. Don't confuse. Now she is keen to conceive, but her histopathology is endometrial hyperplasia with a TPR. What next?
Now,
yeah.
The patient now needs to be counseled that she is keen to conceive, but because it is atypical hyperplasia, the focus of the treatment shifts from infertility towards saving her, saving her basically, because the risk of progression to malignancy is much higher, up to 30% with the risk of cancer for atypical hyperplasia. So now the patient is to be counseled that rather than a treatment for infertility, we have to offer her treatment for atypical hyperplasia, which is of course hysterectomy.
Yeah, very well said. But will you remove the ovaries if you are counseling her and she's really well educated, well read patient and she's asking you, doctor, what about my ovaries? Will you remove only tubes or you will remove ovaries? What will be your take on this?
The tubes have to be removed, but for the ovaries, we can offer her some preservation of the ovarian tissue if she's willing for that.
Okay. Okay. So that was just a catch, because endometrial hyperplasia with a TPR, you have to offer her surgical treatment because that is the first line of management. But we do get some cases where they are very keen to conceive and they are not, hysterectomy is just not acceptable to them. So in my practice also, we counsel them about all the risks, and with progesterone and all, we do offer them fertility treatment. Now this is a third case scenario who is 46-year-old. She has got one living child of 15 years. She has come to you with frequent bleeding from last 3 months. So now we are coming to the coin part. We have discussed the palm part. So Dr. Jyoti, let us discuss this third case who is 46-year-old and who has come to you with frequent bleeding.
Yes.
So can you just elaborate on the role of antifibrinolytics in this lady?
100% antifibrinolytics are the supportive, very important part of the supportive treatment for any case of HMB, especially when you are going for the preservation part. So if the menstrual flow is high, so antifibrinolytics, maybe the tranexamic acid alone or sometime in combination with mefenamic acid is a good choice, and it is very, very well indicated. And there are so many studies which suggest that tranexamic acid in a proportionate dosage, not a very half-hearted dosage, for the management of AUB is very effective. It reduces 40 to 50% of the blood volume, and only few contraindications are there where you have to take the proper history, that they have any previous history of thromboembolism or any reaction to the tranexamic acid, or the clearance part is problematic, like renal failure cases. Only in those cases you will not allow them for that. Otherwise, it is a very, very effective part, and it should be given along with any other management which you are advising them, whether it is some medical management on the hormonal part or whatever.
Yes, very well said.
Ma'am, can I say something?
Yeah, please go ahead.
Ma'am, you had, the case mentioned that she is a patient of frequent menses.
Yeah,
So,
you correct with, okay.
it is not
go
heavy
ahead.
menstrual bleeding.
Yeah,
So
it is
how will
heavy menstrual
tranexamic
bleeding.
acid help, ma'am?
Yeah, it is heavy menstrual bleeding.
Okay.
Yeah. Now, Aradhna, can you cover the role of NSAID in this woman? Aradhna?
Yes, ma'am.
Role of NSAID?
NSAID also is very effective in reducing the bleeding. It is about around 50%. It reduces bleeding, and in combination with tranexamic acid, it has a very good role, and it can be given as long as it is effective.
Yes, and it should be
And
used
while we are
during
preparing
menstruation.
for definitive therapy, while we are planning the definitive therapy, this is a very good option to reduce and control bleeding.
Yes, control bleeding and reduce her pain as well, dysmenorrhea as well. Dr. Vikrant, you can cover the role of COC in this lady because you have tried antifibrinolytic, you have tried NSAIDs, but she is not responding. You want to give her some hormonal therapy. Dr. Vikrant?
I just like to add that he's a radiologist, ma'am. He's basically a radiologist.
Pardon?
He's a radiologist, ma'am.
Okay, okay. So then you can answer. Because two topics are already covered in great detail about the uterine artery embolization and the MRGFUS. But yes, we will take his call on the radiologist perspective on these cases, the overall perspective of radiologist. Vikrant, if you are here, you can just put in your thoughts. Okay, we will go ahead with our discussion and I will invite him to share his thoughts after this case is over.
COCs are very good option, though it is the perimenopausal time. But even in the perimenopause, COCs can regulate the cycles, can decrease the blood loss. And it is not like that, that if the patient is perimenopausal above 40 or having mild hypertension, so COCs cannot be given. They are the a definitive part of the therapeutic option, madam, and they can be taken.
Yeah.
Except for few contraindications, that too in a means COCs लोगों के दिमाग में ऐसे रहता है कि इतना हो गया तो नहीं देना, 35 साल के ऊपर नहीं देना.
No,
It's
yeah.
not such like that. It should be given.
Yeah, it is very safe. Rule out contraindications, do some baseline test, and you can safely prescribe combined oral contraceptives in these cases, that is the perimenopausal woman. Dr. Babita Shukla, can you just, if the COC is contraindicated, how you will give the oral progesterone? What is the role and dose? Oral or injectable or LNG in these cases?
Ma'am, progesterones have got a very good role in patients of heavy menstrual bleeding. They cause deserialization of the stroma and endometrial atrophy, and they inhibit the enzyme which converts estradiol to estrone. And so they help in reducing the menstrual blood flow. We can give progesterone either oral. So we give medroxyprogesterone in the dose of 10 to 20 milligram a day from day 5 to day 26. If we give we can give norethistone acetate also, that is 5 milligram or 10 milligram, maximum up to 15 milligram. We can give micronized progesterone also, that is 200 to 400 milligram. We can give LNG IUS with the advantage that we can put it at LNG IUS, we can just put it in and forget. Just it needs counseling for the first 6 months because of spotting and irregular cycles. But then it has much advantage that it maintains a steady level of progesterone throughout the day, and the plasma levels of progesterone are comparatively low with the LNG IUS in comparison to other drugs, and moreover with the added advantage of reducing the chances of endometrial cancer and also ovarian cancer to a great extent. So any form of progesterone I think is really good.
Yeah, LNG IUS definitely is the first choice, and the cost has been tremendously reduced nowadays. If you just rule out the contraindications, this is the first choice. If not acceptable, then you can go ahead with oral progesterone.
Lakshmi Didi, can
Yes,
I ask
please.
one question?
Yeah.
Here, can DMPA be used in such cases where the cost is the issue, or if it is freely available, like in the government hospitals?
Yes, we can use.
DMPA is very available.
We can use.
You can use because ultimately it causes amenorrhea and it is going to help the woman.
So yes, so
this is the study.
whenever we take the second line as DMPA, because first line is not available in the hospital. So whosoever cannot take, we give DMPA. Otherwise, then the third one is one another thing, madam. 30 milligram sustained release tablets are also available.
Yes,
So is the effectivity is same 30 milligram or 10 milligram TDS?
Yeah. I am prescribing now these sustained release tablets because of the compliance. They have
compliance
to
is
take
very
only
good.
one tablet. So compliance is much better.
Yes.
But directly we don't start with 30. We start with 15 mg. And then if you feel that the sustained release dose is less, then go up to 30.
Okay.
But of course, all hormones, you have to first rule out the contraindications, because you are giving these high doses of oral progesterone in a perimenopausal woman, and progesterone, all said and done, is more prone to cause thromboembolism problem, thrombus problem.
Yes,
so you have to be very, very careful, and you can't go on giving oral progesterone for a very long period of time. That is why I am once again emphasizing that please change your mindset. And as a gynecologist, prefer LNG IUS over your oral hormones. Wherever possible, wherever feasible, wherever indicated, whenever you have a choice between LNG versus oral hormones, always choose LNG IUS, because that reduces the systemic side effects as far as the hormones, oral hormones are concerned.
Agreed.
Because we have seen there was one doctor's wife who was giving high doses of progesterone, and that lady was admitted with cerebral thrombosis in an ICU for 15 days. So just I am mentioning this case not to scare you all, but you all should know that high doses of progesterone has got more side effects as compared to LNG IUS. So this was all about LNG IUS versus the other forms of progesterone, but we have other safer drugs as well in our basket. So Dr. Rita, have you used this ormeloxifene?
Madam,
what is the role? How does it help in HMB in perimenopausal woman?
Madam, ormeloxifene is only non-steroid SERM, selective estrogen receptor modulator. I have using it for the fibroadenosis, fibroadenoma breast. I have never used it for IUB, but it is well documented that it has anti-proliferative effect on the endometrium. So it is very effective in the patients of AUB with endometrial hyperplasia. Second, it is very safe in the patients who have dyslipidemia, who have obesity, where the higher doses of progesterone we want to avoid. Even the patients of breast cancer who are on tamoxifen with endometrial hyperplasia, there we can use it because it has a anti-cancer effect on the breast cancer. So it is a very safe and effective drug, though the trials on the patients on tamoxifen is not available very much because it is only used in India. That's why its role in cases of patients of breast cancer or tamoxifen is not well documented. But we can use, theoretically, we can use in the patients where all the other high doses of progesterone, OCPs.
Not theoretically. I mean, it is used.
Yes.
It should be used because it reduces menstrual bleeding to the tune of 60 to 70%. And there are very few contraindications to its use, and it can be safely used for 6 months to 1 year.
Very good thing about it, doesn't inhibit the ovulation.
Yes.
And doesn't inhibit the hormonal profile of pituitary and ovary.
Yes.
So it doesn't disturb that axis also.
Yes.
So that's why it is very good in that way.
And dosing strategy is also
same, 60 milligram twice weekly for 3 months, and then for 12 weeks, and then weekly once for next 12 weeks.
Yeah, so it's a very safe drug. That is why I have brought this slide for you all. Please use it wherever you feel that it is indicated, and before using hormones in this perimenopausal woman, give it a try. Yeah, anyone wants to comment? Jyoti, you want to say something?
Yes, ma'am. We had done a thesis also on this ormeloxifene, and the results were fantastic.
Yeah.
The one point was there which was written here that long-term effect is also there that we could not found after 3 months or so after stoppage of this. The symptoms were in our study, the symptoms reversal were there, but otherwise not a very costly drug, easily available, very easy to take, because only initially for few months, 3 months, twice weekly and then once weekly, and person can take easily for 6 months and even longer. So
Yes.
we had a very good satisfactory results with this drug.
Yes.
Especially in perimenopause, where you have to control it for not a very longer time.
Yes.
After some time, the menopause.
And as I have mentioned that it is a safe drug because it does not exhibit
And it is a very good
androgenic
option
or
where,
anti. Yes.
yeah, and very good option where the other drugs are contraindicated, like progesterone, or the patient's compliance also, like for hormones, progesterone gives a little slagginess in the patients and constipation and other few things, which is not with this drug.
Yeah. Before I invite the take-home message from all the experts, I just want to tell you all that patient education, patient counseling makes a lot of difference. Because once you tell them that there is medical option available, there are side effects of hysterectomy, if we can conserve your uterus, why not? Believe me, majority of the patients, once you tell them clearly what is the problem, how long they will have to take the treatment, what is your plan of action for their case, they will be with you and they will cooperate with you in conservation of the uterus. So now I invite, I would like to conclude before inviting the panel comments, because then I can stop my slide sharing. So in all the cases of perimenopausal HMB, first and foremost is that you have to really objectively prove that this is a case of HMB. You have to identify and put in your file according to the Palm Coin classification. Systemic workup, rule out pregnancy. Don't forget that she's 48 years old, so she can't be pregnant or she cannot have pregnancy related complications. So rule out pregnancy. Of course, TVS, I am sure you all are going to do endometrial biopsy if she is beyond 40 years or earlier, if she is having a high risk factor or she is not responding to your conservative management, hysteroscopy in selected cases, and of course, medical and conservative approach. Remember, inadequate evaluation and fair trial to medical management leads to most of the cases, this leads to hysterectomy. So it is our duty as a treating doctor to evaluate her thoroughly and give a fair trial of medical management before offering her hysterectomy. Because it is in the mindset, we all have to change our mindset that uterus is not a vestigial organ once the family is complete. Removing the uterus should be the last option and not the first one. Hysterectomy on demand should never be entertained, because after all, it's a major procedure. You never know when you will encounter any complication. So all the focus should be on conservation of the uterus. Do evidence-based counseling. Don't create phobias for uterine cancer. And decision to do hysterectomy is in the domain of gynecologists and not the surgeons. So see to it that she is well counseled, and we all have to try our level best to conserve the uterus. Now I would like to invite Dr. Vikrant, who is the radiologist who has joined us. Dr. Vikrant, are you here?
Yes, ma'am, I'm here.
So in a perimenopausal HMB, what is your perspective, your experience as a radiologist in dealing with these cases?
Ma'am, as far as my experience is concerned, we find leiomyomas and this adenomyosis most common causes, and this TVS is such a nice modality. Its sensitivity and specificity is almost compared to MR in diagnosis of these cases. Only advantage of MR over TVS is we can have a proper fibroid mapping. Sometimes in cases whether we have to differentiate whether it is adenomyoma or fibroid, then MR helps, and we can have a global look uterus in the cases of adenomyosis or endometriosis. For deep pelvic endometriosis and all, MR is very helpful. And I want to emphasize one point here. If there is a case suspected of malignancy, CA cervix or endometrium, MR should be the first line of investigation, not CT scan. Most of the people, they send it for CT lower abdomen. On CT scan, we can only see once the cancer moves outside of the uterus, the spread, the distant spread, local spread, all this. If the lesion is confined in the endometrium or myometrium, it is very difficult to appreciate it on CT. MR is much better for soft tissue characterization. For any suspicion of malignancy, whether cervix, endometrium, uterus, ovarian, MR should be the first modality of choice.
Yeah. So now one line take-home message from all the experts, and then I would like to have concluding remarks from our president, Dr. Shobna Mohandas, on this panel. So just one line taker from all the panelists. Yeah, please.
Madam, your take-home message was like we have to counsel well to the patient. My one-liner is this, that if we can counsel our mind,
yes,
that this uterus can be saved, then we will be able to counsel our patient anyhow. If we are not able to convince ourselves, then it will never be possible. So that is my take home, one-liner take home.
Yes, I can see Chavi. Chavi?
Yes, ma'am. I think the most important fear which is there in the minds of the people, and that is basically put in there by the quacks, is the danger of cancer. So if we increase the cancer screening and then we counsel them, I think that can go a long way in preventing the quacks. Basically, it is we are not doing these unwanted hysterectomy. It is the
not
other.
only quacks, Chavi, the Google doctor is doing all the work for us.
Yes, ma'am.
Even the
so cancer,
practitioners,
cervical cancer and uterine cancer screening should be.
Yes. Aradhna, your one-liner.
Yes, ma'am. I would say that regarding conserving of uterus, office hysteroscope has a more vital role to play, and it should be more commonly used. And with examination and history, differential of palm coin is very well established. And whenever we are suspecting organic pathology, hysteroscopy has an advantage of see and treat at the same time.
Yeah, you can save lot many uterus because you have done hysteroscopy. You are confident there is not, you are not missing anything. Patient is also assured that you are not missing anything. So office hysteroscopy or a proper hysteroscopy has definitely its place in managing these cases. Yes, Babita Shukla.
Like we are all saying that LNG-IUS is should be the first line of treatment. But what I find difficulty is that it becomes really difficult to convince the patient, because what our patients come from the rural areas, they feel like anything in the inside the uterus is not good. Like cancer ho sakta hai aur ye sakta hai, to hum log uterus mein nahi dalwayenge. So we should be more convinced ourselves, and then we should be able to convince our patient, because even after putting it, for the first 3 to 6 months, they have problems with menstruation. There will be spotting and irregular bleeding. And then again, someone will explain them कि ये तो cancer हो जाएगा, बार-बार bleeding हो रहा है. So we should be really good in counseling the patients and helping them out through the first 3 to 6 months. Then and only then will LNG-IUS be successful. Otherwise, it will be removed.
Yeah. But we have to counsel them that LNG is more safe because she is staying in far off place. And if you are giving her high doses of progesterone, then who is there to monitor her? So what you are saying is absolutely right, that counsel her that LNG is more safe. And everything comes down, again, we are coming back to the patient education and patient counseling. Yeah, Rita, then Geeta, and then Dr. Shobna.
Yes, ma'am. Ma'am, the organic pathology, structural pathology, the causes of HMB, polyfibroid. Fibroid is most common. Whenever we find a fibroid in a patient of HMB, we suddenly jump to the management of the fibroid. But there may be simultaneously presence of the adenomyosis and endometrial hyperplasia also. So we should ask, we all are doing our ultrasound ourselves. So whenever it is the reports coming from the radiologist, there should be always comment on the endometrial hyperplasia if it's simultaneously present or not, and if it is present, even if there is a adenomyosis of fibroid endometrial pathology, the histopathology should be done, because it will alter the our line of management if there is a atypical hyperplasia.
Yes, Geeta, I can see
Ma'am,
you want to say something before
our aim
Shobna?
should be to
Ma'am,
improve the women's health. So after finding out the cause, we have to give appropriate management. Appropriate management, it may be medical management, or if needed, hysterectomy also we have to do. If we are doing the conservative management, then we have to reinforce our message to the patient in every visit. Like LNG, we have to, she will come for, I don't want to be with LNG IOD, please remove it. So हमको क्या करना है, हमको उसको बार बार बोलना है, थोड़ी बहुत दिक्कत होगी, इसके बाद सही हो जाएगा. लेकिन आप the complications after hysterectomy, we have to tell her that the ovarian reserve means oophorectomy. We have to do the oophorectomy, and if we are doing oophorectomy, the hormonal imbalance and other causes, she may suffer from that also.
Geeta was saying about fibroid and adenomyosis in perimenopausal women. I am getting very good response with GnRH agonist injections. So you can try this medical management, and these rural women are very happy with the monthly injections, but don't forget to give them calcium and lifestyle counseling, and you can cover and save many uterus. Wherever your diagnosis is fibroid and adenomyosis, just rule out all other causes and give them monthly injections. Anju, your quick comments, then final comments by Dr. Shobna. You want to say something? I can see that you want to share something.
Yes, definitely. First of all, congratulations to you and all the panelists. They have really done a great job. And we all, it's very important for all of us, as Jyoti said, that it should be there in our mind that we have to. Today only, I think 6 patients since morning in the OPD, they were ready for hysterectomy and they wanted the hysterectomy at any cost. And it should be there that we have to tell them that uterus has its own role to play, and hysterectomy is not the answer. And there are treatments available. You have to have little patience, and the things would be fine. And most of the time they will say कि नहीं अभी तो ठीक ही चल रहा है, पर आगे को तकलीफ हुई तो क्या होगा, kind of that. So you tell them that we are there with you. We should try till the last limit. That is very important. And of course, hysteroscopy, as all of us know, is a gold standard. And I have seen we were there, there was a presentation paper in a government medical college also. They are not regularly doing hysteroscopy. So I want to stress upon this need that there should be no blind DNC. No blind DNC. We should, it takes few minutes only to do office hysteroscopy.
And for that, hysteroscopy has to be the part and parcel of PG training.
Yes.
Each and every medical college should have a hysteroscope, so that our postgraduates, when they come out, they are very well versed and confident in hysteroscopy. Somewhere we are lacking in that aspect as well.
So that is where the medical college people have to concentrate. Then when they can buy laparoscope, when they can buy many other things, why not hysteroscopy like a vaginal ultrasound? Why not hysteroscopy in our army?
That is what I'm saying. All the urologists are doing office hysteroscopy.
Yeah. So
that is, madam, doing training by students.
At least, not operative hysteroscopy, but diagnostic, see and treat, biopsy.
We have urology. We used to have urology department initially when I didn't have hysteroscope. I remember long time back. I think about 15, 16 years back, in multi-paras, I used to use the cystoscope from the urologist, my
Yes, yes.
urologist friend,
You
and I
can
used to
use
do it.
cystoscope as cystoscope, or I use my
Yes.
husband's cystoscope if cystoscope is not working.
Yes, yes. So that is one of very
That
good
can be
tool
used.
which we have. So I used to do, initially I started with cystoscope. Now I am doing hysteroscopy also with my hysteroscope and cystoscopy also with my hysteroscope. so it's used for both the things, you
So
know.
Jyoti, you can have one scope and you can do cystoscopy and hysteroscopy in your end. Why should you call urologist for cystoscopy? Each and every gynecologist can do cystoscopy.
I don't call,
I do
hysteroscopy also.
hysteroscopy also with my hysteroscope.
चलो, so we are
एक
waiting.
चीज रह जाती है, दूसरे डॉक्टर के पास पेशेंट ना चला जाए का डर सबसे ज्यादा डॉक्टर को ही होता है। मैं नहीं करूंगी तो ये दूसरे के पास चला जाएगा और दूसरा कर देगा, एंड दैट फियर शुड गो अवे इफ ऑल विल थिंक इन अ सेम वे दैट सबको यूट्रस बचाना है,
सभी को बचाना है, इसीलिए तो डॉक्टर शोभना ने पूरा डेडिकेटेड वेबिनार ऑर्गेनाइज किया है, एंड दैट इज आई एम वेटिंग फॉर हर कमेंट, एंड आई एम श्योर आई हैव नॉट मिस्ड एनी पैनलिस्ट फॉर वन लाइनर. I can't see everyone. Neeti, I miss you. Yeah, Neeti.
Yes, ma'am. Ma'am, I just want to say that we should keep in mind that there are 25 to 50% chances of ovarian failure in a lady who is undergoing premature hysterectomy. So we should think twice or thrice or 100 times before taking her for hysterectomy. This is my take.
Yes.
For preserving.
Dr. Shobna, coming back to the guru mantra on this.
I don't know. All
Conserving
the
the
gurus have
uterus.
said everything.
Now you have heard all the aspects from everyone.
I learned so much today. I think Jyoti is using DMP. I have never used it. And let me tell you, 30 milligram of this registron or whatever, I use it only primarily, what do you call it? Norethistron, sorry. I use it only for acute stoppage of bleeding. I don't routinely use it. However, the company people come and give you, but I give it in tapering doses. This is my take on it. And yes, life is not so simple that they'll come to you only as DUB or only as adenomyosis or only as fibroid. And quite often I see that in my patients who come as DUB, pelvic infection is quite often missed. Nobody does a PV, and it is quite often endometritis which is missed. And I thought that aspect also had to be covered in the panel. And the dose of megestrol in patients with endometrial cancer, that will come later. But otherwise, I think you have covered everything to save the uterus. And I have had patients where I was juggling between, you know, this different drugs. Thoda estrogen try karo, fir baat kya aayegi, fir thoda progesterone try karo, fir thoda wo Sevista try karo, fir wapis ispe chale jao. And then they go on and on and on. I have had persistent patients, but very few of them. Most of them get tired of it. Yes, you did not mention that adenomyosis and fibroid, it's not just GnRH analogs. We have covered it in other presidential webinars, but the use of cabergoline, use of levetiracetam, all these things are also very useful. I think we are overshooting time, but if anybody else wants to share their experiences, presidential webinars are always for sharing your personal experiences more than theory. So if anybody wants to share their personal experience, please go ahead.
Yeah, I just want to add one thing, you know, in 3-4 of my patients, when I did a hysteroscopy, I found the endometrial cavity was full of, you know, those endometritis we could see very clearly. And those patients, when I treated them with the antibiotics and this thing, they have responded very, very beautifully.
That is what Dr. Shobna said.
Was negative. Of course, their PCR was negative.
That is what she said, ki infection is also another cause which should be looked after. And when we start them on hormones, do ask them the history of compliance, because I have come across few patients who don't take your hormone tablets properly and they go on coming to you with bleeding.
Yeah, so that they regularly do. They think it is like a chocolate. And
yes,
bleeding, they take one tablet and then they come.
आज लिया कल भूल गए फिर भूल गए ऐसा तो compliance
should be blame the tablet for everything.
Yeah, compliance should be rechecked if she is on hormonal treatment. Okay. Yes, anyone wants to share any personal experience before I hand over to Amrita? Yeah. Amrita, back to you.
Thank you. Wanted to ask one question regarding UAE if the sir is available.
Can't see.
No. I don't think.
But UAE Jyoti is available, I think, at every place because Nagpur, our radiologists are
My
routinely
department
doing,
also having UAE, madam.
and each and every medical college is doing uterine artery embolization.
We are doing uterine artery embolization, and I just want, because it remain always in our mind that if the patient is wanted to preserve the fertility, so this is not the first choice, definitely.
Yes, definitely.
It's not the first choice, but like I had sometimes cross with the patients who had by chance having the chance means they have gone to the radiology department, and the radiologist without much thinking about the fertility aspect, they have taken the patient for the UAE. Later on we have a fight ki isko nahi karna tha, whatever. But later on, after 6 months, patient was very well responded to it. So she was so happy. She again went for the second fibroid for the UAE for the second. She has a 2 big fibroid, 32 weeks size of the uterus. And obviously the myomectomy of that much big fibroid is also a bloody job. It's not an easy job.
No, Jyoti. Such myomas, they come out very easily.
Yes, big myomas
32.
come out
It's
very
the jaldi
easily.
aa jata. That's not the point. Why did they reach that size? That's what I'm asking.
The patient was not shown earlier any time, and she came with the almost 30 week size uterus, madam, with the fibroid which was reaching towards the endometrium and also coming outside also. So the 2 to 5 kind of myoma.
The multiple fibroids are the ones which
She has
bleed a lot,
only
not
two
one
fibroids.
single big.
She has 2 big fibroids, others were very small, but she has that fibroid stretching very badly the endometrium inside and also extending outside up to the broad ligament. So that has undergone UAE. After that, she was comparatively quite happy. So she has gone for the second UAE also. But after 1 year, even after 2, so I wanted to ask that 2 times UAE are really good. Should she go for that? Number 2, after 1 year, she has again reversal of this thing. The size of the fibroid was less, but the bleeding again restarted, heavy menstrual bleeding. So finally, she has to undergo for myomectomy.
Jyoti, he had already elaborated that the result is around 70 to 80% in all the symptoms. Starting from the size to all the symptoms, they respond to around 70 to 80% only. And the recurrence is maybe there because it was a big fibroid, so recurrence is expected.
It may not be recurrence, it could be de novo appearance of another fibroid.
No,
I
madam,
don't,
it was.
Yeah,
it was
that's there. Uterine
Jyoti,
artery embolization, it is recurrence. Yeah.
Jyoti, he clearly said that any fibroid which is going submucous.
Itna bada hai, so I don't know why you do
And
UAE.
going
I would
submucous
rather
is
do
going
a
to give problem. So this
Yes.
fibroid he said was going submucous, right?
It was
No. He said
it was grade 2 to
intracavity
5.
should not be taken. No. He said intracavity should not be
Anyway,
taken.
we will take a few years of people like Jyoti Jaiswal from medical college. They have a facility in medical college. They'll give us data. Because private with we can't experiment so much.
Yeah, we can't.
It was not an experiment, madam. It was an accident.
She was a case of infertility, Jyoti.
Yeah, she was an unmarried girl, madam. 27.
I think she was.
Private
She was.
selection was not myomectomy for her.
She
I
was
would never do
better
a
fit.
UAE
Better
for
fit for a myomectomy.
That is
at
what case
very
selection
stage.
was not proper.
She was being fit for
That big
myomectomy,
fibroid.
gone for the mapping there and got the UAE done.
So how come these people take the cases directly? Don't you refer these cases to them, or they have a clinical OBD for them?
She was gone for the mapping. She was gone for the mapping, and because
they
of
took it.
miscommunication between the professors, it has been done.
Okay.
A good fight must have been there.
Chalo, it was an accident. So now Amrita, back to you.
Okay. Thank you, ma'am, for a wonderful panel, and thank you all the panelists for great inputs, and Shobna ma'am for the final word. And at the end, before signing off and saying good night, I would like to thank everybody present here. And with deep gratitude, I thank Dr. Jignesh Shah, our chief guest. He is traveling, but still he was kind enough to join us. And my hearty thanks to our guest of honor, Shobna ma'am, IMS president, who gave me the opportunity for organizing this conference. And she also joined when she is so busy with so many personal meetings and the meetings going on online. And I would love to thank the chairpersons who were kind enough to spare their time, and they enlightened us with their remarks and inputs. Thanks to Dr. Anju Soni ma'am, Dr. Bipasa, Dr. Radha Jina ma'am, Dr. Seema Sharma ma'am, Dr. Ragni Agrawal, and Dr. Reena Srivastava madam. Thanks to our eloquent and brilliant speakers. They really showed us that the future of medicine is now high tech, and it is going to be expensive. We hope and wish that more and more patients get benefited with their skills and the new technologies. I bow down in front of Dr. Lakshmi ma'am, and what a great panel. And the panelists, wonderful panelists, Dr. Jyoti, Dr. Babita Shukla, Dr. Vikrant, Dr. Chavi, Dr. Aradhana, Dr. Neeti, Dr. Geeta Gupta, and Dr. Rita Singh. And thanks to the audience, and they spared their time with us. And thanks to Clarinet for giving us this platform. Thanks to Paresh Bhai for helping me out. And I'm sorry if I've missed anybody out here. Thank you all and have a good night. Thank you.
Just Sarkari madam, just a request from my and Shobna madam's side from the Gorakhpur Society to please submit forms for the Pan-India study of hot flashes.
Yes.
Kindly contribute for 200 forms for this study. So this is a take on the madam's this thing for Pan-India study on the hot flashes, and you must have the format. If you do not have, I can send.
No, I have. I'm sorry, I got it printed also.
Amrita, ask members to submit at least 20 cases each, and you'll have from 10 people.
Thank you so much.
Yes, ma'am. I got them printed also, but somehow it's there. Okay, I'll be doing that.
I will call you again.
You are an active society, Amrita, you will be able to do it.
Yes, we will.
Gorakhpur is very active, Dr. Reena. We expect lot from you.
Yeah, 10 दिन में हो जाएगा. Amrita?
Yes, ma'am.
कल से लग जाओ. 10 दिन में हो
Sure,
जाएगा.
sure.
Oh, thank you, Reena madam.
Okay,
Then
thank
Dr.
you
Reena is
everybody.
there, nothing to worry.
we have to start collecting now because we have to start the collating work. Jyoti is going to do.
Okay.
Thank you so much.
Thank you.
Thank you. Bye everybody.
Good night.
Good night.
Thank you.